Brad, for maybe the first time since I've known him, seems to be silenced. There's some technical difficulty, so I'm going to take advantage of that, and I'm going to start. We have gone through a number of questions that we decided I should deal with, and so I'll just start. So first of all, welcome to everybody. I hope all of you are fine. As far as I know, there are no cases of COVID-19 coronavirus in anybody with AT anywhere in the world. And probably the most difficult problem that most of our families are having right now is related to the social isolation and not to the coronavirus itself. So let me start by talking a little bit about what a virus is. A virus is very different than any other kind of germ or any kind of other cell. So all the cells in our body, except the cells in our brain, have the ability to grow and divide. And your brain cells actually have that ability before you're born. For whatever reason, that's stopped later on. But cells have the ability to, on their own, grow and divide and make more cells. That is also true for all kinds of other germs, like bacteria. So bacteria you can put into a test tube all by themselves and give them the food that they need and the temperature that they need, and they can divide and multiply and grow on their own. Viruses are very different. A typical virus has some kind of nucleic acid, so that's a genetic code. It could be DNA or it could be RNA, and that's at the center of the virus, and it's surrounded by some type of a coating. And the purpose of the coat is to protect the genetic information and to allow the virus to attach to and then eventually penetrate some type of a living cell. So for coronavirus, the coating on the outside of the virus allows that virus to attach to cells in the throat, in the nose, and then all the way down the respiratory tract, down the airways, and into the lung cells. Once the coronavirus has attached to the cell, that coat then facilitates the transfer of genetic material from the coronavirus into the cell and eventually into the nucleus of the cell. And once it's inside, the virus DNA or RNA takes over control of the cells in the respiratory tract and essentially tells the cell to stop doing everything else it's supposed to do and give it a new job. And the only really new job that the cell has is producing more and more copies of the virus. So the rest of the cellular, or most of the rest of the cellular machinery, stops. The cell makes more and more copies of the nucleic acid at the center of the virus. It makes more and more copies of all the proteins that are needed to put the virus together. And in this case, the lung cell, or the cell in your throat, fills up with more and more complete copies of virus until eventually that cell explodes and it releases millions of additional copies of virus, which then can spread out and infect other cells in the area. So a virus is kind of like a parasite. It can't grow. In fact, it doesn't really survive on its own. It's just kind of an inert particle, piece of genetic information surrounded by protein. And its only purpose in life is to find a cell in which it can invade and then make more copies. Now you can imagine.
Howard, can you hear me?
I can hear you now.
I'm live and well.
Okay.
This is Brad from the AT Children's Project, and sorry I'm late. We had technical problems, but can I interrupt something? So
Sure.
You talk about viruses, and now you've explained that they're little pieces of RNA and proteins that reproduce in our bodies. But how come some viruses can be passed through the air and some viruses can only be passed if they're touching surfaces or you have to make contact or through your body fluids? What makes some viruses so much more easy to spread?
Primarily, that depends on how sturdy the virus is. So there are lots of viruses that, essentially all respiratory tract viruses spread from person to person because they get stuck on something, and a person, well, let me back up. A typical respiratory tract virus, like a cold virus, rarely spreads from person to person directly through the air. And there are cases when that happens. If I'm holding one of my grandchildren in my lap and they turn around and look at me face to face and they sneeze or cough and I get a glop of mucus right in my mouth or right in my eye, then chances are I'm going to catch that virus. For the most part, it's relatively difficult to spread respiratory viruses. You have to have a certain number of them. And when the virus lands on a surface, it doesn't survive for a very long time. But most of the time when we spread colds, somebody sneezes or coughs, and pieces of mucus with virus in them land on a surface. So they may land on your computer keypad, they may land on a doorknob, or you may use your hand to wipe your nose or wipe your mouth and get it on your hand. And then you touch something else. And the next person who comes into the room touches that doorknob with the virus on it or touches the computer keypad, and they get the virus on their hand. A respiratory virus on your hand will not cause an infection. It only causes an infection if that respiratory virus ends up on what we call mucous membranes. So that means something that looks like the lining of your mouth or the lining of your nose. So if you get the virus and that mucus on your hand and you rub your eye, or you pick your teeth, or you pick up a piece of food and you get it on the food and you eat the food, any of those things will transfer the virus into your own system and allow the virus to then attach to a mucous membrane and cause an infection.
Okay, so let me ask you, since most of us on this call, and there are hundreds of us, I understand, are related to people with AT, can we just ask you, let's talk about the risk. Why are we particularly worried about kids with AT getting this virus? Viruses in general and their effect on AT kids, but so it's partly because of the immune system? Is it also partly because maybe the lungs don't work so well in AT? Tell us a little bit about the reason why we need to be more concerned.
Well, anybody who has chronic lung disease is at higher risk for having a tough time getting over coronavirus, COVID-19. We know that from lots of studies and lots of populations. So people who have chronic lung disease for any reason, and certainly AT is one of the reasons that people get chronic lung disease, have lungs that are already damaged and are more susceptible to more damage and are less able to manage with the stress of getting a new infection.
So can you just explain what you mean by chronic lung disease for AT? So if you have a 8-year-old with AT, does he or she have chronic lung disease? Is chronic lung disease just mean lungs that aren't very healthy, that have trouble sometimes getting liquids in them and aspirating? Or what does chronic lung disease really mean? Like if you're listening to you right now, how do I know if my kid has it or not?
All right. So first of all, anybody who is using oxygen, anybody who needs oxygen at night, has some degree of a problem with their lungs. People who have had recurrent infections in the lungs, recurrent pneumonia, recurrent episodes of bronchitis, I think we could assume have some degree of chronic lung disease. But the vast majority of our kids, certainly under the age of 12, don't have lots and lots of lung infections and are still able to breathe in and out and are not having problem aspirating and are not having particular problems coughing. And they probably are not any more at risk of having a bad problem with this infection than anybody else who's 8 or 10 or 12. Now, over the older somebody gets with AT, the more problem they have getting a good strong cough, the more problem they have with aspiration, and the more likely it is that they're going to have some degree of lung disease.
Okay, so if someone with AT is older and has those problems, maybe just coughing alone is difficult, then this is a lot scarier for them than for a totally healthy person to get the virus. What about the immune side of it? If of course, not all AT kids have the same degree of immune problems, but explain that. Would that impair or reduce your ability to fight this virus?
All right. So the immune system response to this virus is complicated, and I'm honestly not sure whether AT immunodeficiency may be beneficial as opposed to detrimental. So let me put up a slide. This is going to be kind of complicated, but I will walk everybody through it. There we go. All right. So the response to a virus is very complicated. Can people see the arrow on there? Brad, can you see my arrow?
Yes, I think
yes.
So.
All right. So this red thing called pathogen, just for the sake of this call, let's call this COVID-19. So when a virus gets into your mouth or into your nose or anywhere in the respiratory tract, there are lots and lots of mechanisms that we have for recognizing that that is a germ and we need to get rid of it. So there are cells called natural killer cells. There are molecules called complement. There are a whole bunch of other molecules not even on this slide called toll-like receptors. And all of those things together within minutes can recognize that there is a virus there and that that virus ought to be killed. And over the period of that's starting in a few hours and will probably last for a number of days, there are what are called innate immune system, which means that you don't have to learn how to respond to coronavirus or any virus. There are these systems in the body which will attack the virus in a whole variety of complicated ways. And they will kill virus and limit the ability of that virus to spread from cell to cell. And as far as we know, all of the pathways on the left-hand side of this slide are completely intact in people with AT. And I would expect that that should not be inhibited in any way because somebody has AT.
So the things on the left, the innate immune system.
Right. This is the initial response.
They are kind of the automatic initial response. It's not specific to a particular virus or anything. It's just it reacts to anything foreign that comes in your body that shouldn't be there and attacks it. And you're saying that's pretty much the same. Even if you have AT, it works pretty well.
Yeah, we don't have.
So I'm guessing that right now
we don't have any evidence that anybody
system,
is got a problem with that.
So the only problem seems to be that it sounds like that doesn't work really well in protecting you from COVID-19 because people do continue to get sicker, even though after the first few days. So the thing on the left, that system, what you call innate immune system, is not adequate to fight the virus. Is that right?
So I think that's probably wrong. It seems that the vast majority of people who get COVID-19 probably have very mild or maybe even no symptoms at all. And
most of the time, this system works. Then.
So most of the time in most people, this system all by itself probably limits the infection to the point where this is a very mild disease or completely without symptoms.
So now, even if you're an AT kid, you may, the majority of the time, vast majority of the time, your system that works, the innate, the immediate automatic response, may do the job in protecting you or helping you get through the virus.
That would be my prediction.
Okay.
Okay. Now,
does this system, by the way, get worse with age, or does it, whatever you have it even with AT and doesn't really change?
Well, every part of your immune system gets worse with age. I would say for the most part in people without AT, we're talking about things getting worse over the age of 50 or 60. But again, I don't have any good reason to think that in a 20-year-old or a 30-year-old with AT, that anything is going to change about the way this part of the immune system works.
Okay. So tell us about the other part of this immune system.
All right. Now, once you have a lot of cells that are infected, there are two primary ways that we have of killing the virus. One is that we generate T lymphocytes, and those T lymphocytes can sometimes directly attack an infected cell and kill that cell. So that's what's shown up here. The other thing is that certain T cells will produce a whole variety of what are called cytokines, or proteins that create and enable an inflammatory response. The third thing that happens is that you can get these other cells called B cells, and they make antibody. Now, again, in the vast majority of people with AT, the ability to make antibody seems to be pretty normal, but there's about 15 or 20% of people with AT who have an impaired ability to make antibody. On the T cell end, it's very common that almost all of our people with AT have low numbers of T cells. The T cells that they have work, but they have a much smaller number than normal, and that may cause some problem in killing off infected cells. But what happens with COVID-19 infection is very curious and not well understood. In general, what happens is people get infected, and if you're going to have symptoms, the symptoms may be mild for the first few days or first week. And then after a week, in some people, instead of getting better, they tend to get much worse. And it seems that they get much worse because this T cell response is overactive. And what makes it worse after 7 or 10 days is not that there's so much more virus, but that the person's own response to the virus is overactive and causes lung damage all by itself. So my prediction.
So wait. So let me ask you what you're going to say. So, are you saying that even though so one of the problems with COVID is that your immune system, especially this T cell part of it, overreacts, and that if you're an AT kid who has fewer T cells, you might be a little bit in better shape because you won't overreact? Is that what you're saying?
Now, again, this is an educated guess, and it's only a guess, but that's what I might predict. If you look overall at probably now a collective amount of 7,000 or 8,000 COVID-19 patients who have been sick enough to get into intensive care units, there is a propensity for those people to be older. There is a propensity for those people to have other underlying problems like diabetes or chronic lung disease or high blood pressure. But there doesn't seem to be any big extra risk if you are immunocompromised. So people that have gotten chemotherapy or are on steroids, which are other things that would damage this T cell response, don't really seem to be a big factor in driving people to get into an ICU and have really bad COVID-19 disease. So that, I think, should be somewhat comforting, although this is a big black box, and exactly what happens in an AT patient in general is hard to predict, and there's a tremendous amount of variation from one AT patient to another.
Okay, so let's review. So your immune system includes this innate response, which is the immediate response, and that response in AT may be the same as in healthy people, certainly when you're younger. And then on the T cell part, AT patients tend to have lower T cell counts, but that may not be a problem. It doesn't seem to be with other diseases where you have low T cell counts. Then you have this last thing, which is you mentioned, which is your B cells and making antibodies against that virus. And so how are AT kids going to do with that?
Well, again, the majority of kids and adults with AT do a pretty good job of making antibody either when they get infected or when they get a vaccine. The people that I would be worried about in terms of ability to make antibody are the people that are on gamma globulin because they're having difficulty with that process.
And what percent of the AT kids out there do you think are on gamma globulin?
Probably 15, maybe 20%. So the majority are not. Now,
so why don't we talk about them, since they're going to be on this call and listening and probably most worried by what you're saying about antibodies. So if they are going to struggle a little more to make antibodies, that makes them more vulnerable. Is that right?
So again, I'm not so sure about that. So I have AT and non-AT patients, probably altogether 600 people that I take care of who have antibody deficiency. Now, I don't have very many that have gotten coronavirus. I've had a couple, and I have lots of them that have gotten other respiratory tract viruses like the flu. And in general, they don't seem to have a harder time getting over the flu. The problem that you have if you can't make antibody is that you could go through this whole process, you could get infected, you could get over it, and if you can't make antibody, you could be reinfected. So I think the major role of antibody is probably that if you've already seen that infection or you've been immunized, that you will have antibody pre-existing, which may prevent the infection in the first place.
Got it.
So I think people that have AT that are on gamma globulin are not going to get protection from that gamma globulin because there's no antibody in the gamma globulin pool to this new virus. And they will also probably not respond to a vaccine if or when one is available.
Got it. Okay, we're going to want to move on to a lot of questions about what AT families can do, but now that you've explained to us how viruses infect and how this virus which parts of the immune system it affects and how AT kids respond versus other people, what about any other facets of having AT that could affect how you respond to this virus? For example, you have neurological problems that make you less coordinated and have maybe weakness in your ability to cough or hang in there and keep coughing. Are those kinds of things you have to worry about? Is there anything else about having AT that might make your response to this virus different?
Okay. Jennifer, why don't you turn that slide off because we could just make the view bigger. So I would say the thing that I'm worried about the most is that if you have AT, it can be more difficult than normal to breathe in and out, especially if you've got some kind of an infection in the lung. It will be more difficult to, or it may be more difficult to cough and get mucus up. And I think it's going to be more difficult to go through this process without getting tired out. So the people that I would worry about are mostly going to be older patients who have some difficulty breathing, people that are not skinny per se, but undernourished, that don't have a lot of muscle. So I think that's probably the second group of people that I would worry about in terms of stamina.
And are there things that you think would be done differently if your child with AT were infected and started to have problems and you took them to the emergency room? Is there anything that you would, what you know about AT, having seen so many kids with it, is there something you would advise the emergency room doctors to do differently to an AT kid than how you would treat other people with the virus?
I would just be probably a little bit more cautious about looking at respiratory effort, especially if you had an AT patient that was a little bit older or a little bit more fragile for whatever reason, and would probably have a lower threshold for admitting somebody to the hospital for monitoring of oxygen status. So lots of people with COVID-19 come in the emergency room. They have mild symptoms. Their oxygen levels are fine. And since we don't have a specific treatment, we send them home. And we have them come back only if they're having difficulty breathing. And that judgment about how much difficulty breathing gets you in the hospital, I think should be altered a little bit in somebody with AT, especially somebody who's a little bit older, or somebody who is poorly nourished, or somebody who is just in general weak.
Great. So can we move to talking a little bit about
now?
Go ahead.
Let me just say. So the other thing is that there will soon be opening trials for pediatric and adult patients who are immunocompromised or at some other extra risk for having a bad outcome with COVID-19 infection. And the one that I think would make the most sense would be one of the trials in which you could get plasma from somebody who has gotten the disease and is now recovered, because that's a way of getting antibody in. And especially very early in the course, that antibody may have a good effect.
Good. So where would these trials be run? I mean, are they going to be everywhere, or are you aware of anything just for AT or for?
I don't know anything specifically.
AT would fit?
I don't know anything specifically for AT. There is a program. We've just gotten FDA approval to do this in people under the age of 18 that are immunocompromised. And I'm hoping that within about a week or so, it's going to be open and running at Hopkins. And we've shared our protocol with, I think, about a dozen other pediatric medical centers around the country, and we're happy to share it with any number of them who want to join. So, so that's a possibility. And there's a similar trial that has just been approved in adults who are compromised for whatever reason, and AT would fit into that rubric.
Do you think that you'd want to, or that it would be valuable to do this for all AT patients, or those in the 10 or 20% you said that really have trouble making antibodies?
Well, I think if I had a patient with AT who had a bona fide infection, that I would be thinking about using this. Again, not everybody's going to have a hard time, and I'm not sure how much supply there's going to be of this plasma. So if I had a 3 or a 4 or a 5-year-old who was otherwise fine, I certainly wouldn't be panicking about it. But if I had an older patient with AT, I would. People should get in touch with me.
Okay, we will.
Okay.
So let's move on for a second to just we got a lot of questions from people about how to live in this environment right now, not with a child that's infected, but just how we all strive to avoid getting infected. So the challenge right now, of course, is to isolate and do everything we can, even more so than most people, to prevent our children from being infected with AT. I mean, with the virus, but that's going to get difficult as the world opens up a little bit, and either parents are essential workers that still have to go to work, or all parents and members of the household have to start going out in the world. And so do you have any advice for how to avoid the infection, or how to decontaminate? For example, if I go out into the world for business and I come home, do I need to be quarantined for 2 weeks before I can hang out with my family? We have a lot of parents, AT parents, that really won't be able to just hide and isolate themselves with their AT kids.
So this whole isolation, quarantining system is one in a state of flux, and it's really one for which data is not so great. It's very clear that if you touch a contaminated surface and you get it on your hands and you rub your hands in your mouth, so basically anywhere on your face, that you're going to have a significant chance of getting the virus or transmitting the virus. So I think for everybody, the most important thing is to be really careful about washing your hands. So when you go into the grocery store, you bring some Purell with you, and I usually just wipe down the handle of the cart before I get started. And I think wearing a mask, I'm honestly not sure how well a standard mask protects the wearer. Okay, I think if you've got an infection and you're wearing a mask, it probably cuts down the chances that you're going to spray droplets all over the place. But I'm not sure how much the wearer benefits, except that wearing a mask reminds everybody to keep your hands off your face. And even if you make a mistake and you put your hands on or near your face, you touch the mask, you don't touch your face. So I think wearing a mask when you're out, now I think wearing a mask when you're going for a walk doesn't make any sense. But I think wearing a mask when you're in a grocery store, wearing a mask when you're in proximity to other people, that makes sense. And I think being really careful about your hands. So you get what you need in the grocery store, and you get everything put into your car, and you Purell your hands. And when you get home, I would do the same thing. Once I get inside, the first thing I always do when I get inside my house is I wash my hands. There are lots of experiments that have been done where they take COVID-19 or some other virus and they put it in a machine that makes very fine particles and can shoot them 26 feet or 30 feet, that shows that you can spray COVID-19 all over the place and it stays up in the air for a long period of time. But nobody has an aerosol generator like that. And for the most part, when people sneeze or cough, those droplets go about 6 feet and they don't go farther than that. And they land on a surface. And unless you touch the surface and get it on your hands, you're very unlikely to have a problem. So I think in general, if you've got a parent that needs to go to work, they go to work, and what they have to do at work really depends on what they're doing. So if they go to work and they're in an office by themselves, I would say from the time that they park their car until they get through the office building until they get into the office, they should be wearing a mask. After you get into your office, you wash your hands, you take off the mask, and you can stay in your office like I am right now with that mask around my neck but not wearing it. And at the end of the day, you reverse the process and you wash your hands. I don't see any reason that you've got to strip before you get into the house or change all your clothes or run right into a shower. I don't think that makes sense. Now, there are certain people where I think the risk of spray are going to be greater. So if a parent was a dentist, I would be nervous that the spray from all the things going on in a dental exam could get on their clothing. And so my suggestion is that anybody who's got a job like that should go to work, should put on protective gear over their clothes or instead of their clothes, leave that protective gear in the office, and then come home in street clothes.
So what do you think what's going to change that will make it a little more of an all clear signal where we will feel more comfortable? I mean, just start with things like going to school, an AT kid going to school, or returning to normal activities in groups. I guess one question would be, it just seems really uncertain right now still. And I guess one question would be, if testing becomes more available, do you think testing is something that AT families should maybe find a way, lobby to get done more often for them than for the general population, or would that make no difference?
The only real testing that would make a huge difference for somebody with AT is if they had an antibody test that showed that they had already been infected, didn't know it, and were now immune. Okay, so if you had some young child with AT who's infected and is recovered and has antibody, they are probably not at significant risk to get reinfected, and that would allow you to just release restrictions. Now, I think that there's probably not many AT kids that are going to get into that category, because I suspect when all of this started, everybody who has a child with AT put them in a cocoon right away, and has kept them really isolated. So my bet is most of our patients have not gotten this virus.
And just so to be clear, it may be a little early for that, right? I mean, my understanding is the antibody test still has a high error rate, and even if you come up positive for antibodies, it's not necessarily clear how much how effective they are in keeping you immune, or how long your immunity would last. A lot of things that have to still be figured out, right?
All of that's true. Again, I'm trying to make educated guesses, but I think I think antibody testing for most people with AT is not going to be very helpful. I think if you had let's say a working adult in the family who has gotten COVID-19 and has recovered, they probably are at low risk of getting it again and bringing it in the house. Again, it's my best guess. And so maybe that would be one of those cases where you could be a little bit less paranoid. But I think the issues are going to vary from community to community. So I'm sure there are small towns and places that have just not seen very much COVID-19 at all, where the risk is low. I think there are people who have jobs where even if they go to work, their exposure or proximity to other people is low, and they're not very likely to bring it back. And what's going to happen with schools, I think, is a big open-ended question right now for everybody, not just people with AT.
Yeah. So can we ask you? We got several people who've asked, can any of the other things that we currently do for AT kids to kind of keep them healthier help in this situation, such as there are pneumococcus, pneumonia vaccines that quite a few AT families have had given to their children. Although those are helpful, they really protect you from another kind of virus that can cause pneumonia. And if you get pneumonia from COVID, having had those vaccines wouldn't make any difference. Is that right?
That's correct.
So,
but it does prevent you from getting another respiratory illness. And if you already have pneumonia from some other cause, and then you got COVID-19 on top of it, that will be a bad combination.
So assuming we can avoid being contaminated from going to do it, when flu vaccines become available late this summer, early fall, is that something, once again, all AT kids should get? Everybody
should get a flu vaccine. AT kids and all their family members, for two reasons. One is that the flu is something that really damages the airways, the lining of the airways, and makes you much more susceptible to a second infection. And the second one is that a lot of the symptoms of flu mimic the symptoms of coronavirus. So if people start getting the flu, there's going to be a flood of people worrying about coronavirus, and a lot of people worrying about coronavirus testing who may not need to have it, because if they don't get the flu, they won't have those symptoms.
Great. And I guess if a vaccine is developed for COVID, will it be the kind that is okay for an AT kid to get, whether it's a dead versus live vaccine and that sort of thing?
Yeah, there's no vaccine that's in the process of being developed that I'm aware of, which is a live vaccine. So all of the COVID-19 vaccine development is going to lead to some product that will be completely safe. Whether it works or not is another question, but I'm not worried about the safety for anybody with AT or any other kind of immunocompromise.
And can you tell us anything about the status of some clinical trials for AT that have been ongoing, and what this will all do to that? So, for example, the Iridel trial, which is the trial of a steroid, loading into your plasma, but quite a few AT families have participated in that. Are those on hold? They're going to reopen? Should families still participate? Should they take road trips instead of flying to them? Any comments on that? We've got several questions about that.
So I am nervous about people that are immunocompromised being in crowds. So I think the airplanes probably don't qualify anymore as crowded areas, but I'm more worried about the airport, where there are lots of public spaces, and I imagine that there's a few more people around. I don't know, maybe Brad's got more direct experience with that than I do. But I would say, first of all, there's a lot of states that have restrictions on travel, and so I would not violate a state's or a local area's travel restrictions in order to stay active in most of the clinical protocols that I can think of that are running right now for AT. What we're doing at our center is we are allowing people to come if they can get here by car, but not allow them if they need to take a train or a plane or some other kind of public transportation. And if they're not coming from an area where there's a very high risk that they could be bringing COVID-19 down to us. So right now, I wouldn't allow anybody from Manhattan to travel to Baltimore for much of anything. And I think if there was some life-threatening illness, that would be different, but not for a clinical trial. But if we have a family that's in suburban Maryland or in some small community where there's very little COVID, where the family has been isolated, I think having them get in a car and coming down for a clinical trial is something's got to be thought about individual by individual, but that I wouldn't say is necessarily a problem.
We received a question from a family about exercises, lung exercises. Is it something that would be beneficial, or is it kind of too late? If you want to strengthen your lungs, they would have had to start a long time ago.
Well, exercise in general is always a good thing. I would say for most of the people with AT under the age of 10 or 12, there's probably no point in doing any kind of lung exercise, because I think their lungs are probably fine and their ability to get air in and out is probably fine. And just exercise by walking around the block or by pedaling or by moving in whatever way is probably good enough. For people that are very sedentary, trying to do a little bit more in the way of any kind of cardio exercise is probably a good thing, but certainly not something that's going to change any lung or heart function in a week.
Great. So I think we are going to probably wrap this up. I think the chat board is open, so if people want to submit any comments on this webinar, what you thought of it, or whether it was valuable, or whether we should have another one, we'd love to hear from you. Dr. Lederman, thank you very much for doing this with us. I think it might be a good idea to do one maybe in a month or so. The world is changing really quickly, and we may know a lot more about promising treatments or vaccines, and also whether the world is opening up or whether we're still stuck at home. But I hope everyone has found it helpful, and we'll be in touch soon. So thanks again, Dr. Lederman.
My pleasure.
Any
Everybody
final
should
comment
just, no, I just hope everybody stays safe. And certainly if anybody's got an AT patient who's diagnosed with COVID or has a really bona fide strong exposure to somebody who's been diagnosed with COVID, I'm happy to hear from them and then try to help with whatever specific circumstance comes up. Great. And I think if there are questions that come up, I don't know, Jennifer, how long this chat system works, whether it ends when the call ends, but I'm sure if you send questions to Jennifer that we can figure out some kind of a way for me to answer them and then get them back out to the group. I'm not going to be able to answer a specific question about a specific child that I'm not, actually seeing, but I'm happy to answer any kinds of general questions that come up.
Great. Okay, everyone. Thank you very much for joining us. We're signing off now.
Okay, thanks for setting this all up.
Sure.